Do you feel tingling, shocks, burning, and are unsure if your nerve is compressed? Then, stay here until the end because we are going to talk about the diagnosis, symptoms, and what to do to improve this problem. Today we are here with Deborah, who is an occupational therapist. Deborah, what do you see in a patient who has symptoms of a pinched nerve?
So, I will look at the history when they feel this compression. So, usually the sign that comes to us, the symptom, is either tingling or paresthesia. So, these two signs, for me, are indications that the nerve is really trapped, compressed.
What type of patient with a compressed nerve do you see the most currently?
I treat the ulnar nerve at the elbow level and the median nerve in the wrist.
The ulnar nerve is the one that causes tingling in the little finger, right? I want to know, what is the main cause of ulnar nerve compression that you see today in your office? What is the cause? A patient who uses their cell phone, a patient who keeps their elbow bent on the table, a patient who does very intense weightlifting, sometimes has very strong triceps?
It's exactly those three, but the most common is using a cell phone with the elbow very bent, either when resting the arm, or when sleeping, or when watching TV, spending a lot of time on the couch with the elbow supported. The last one, I see less often, but I do have quite a few patients who engage in physical activities, not just weightlifting, but also patients who do Pilates, which, in some cases, significantly worsens the ulnar nerve.
Folks, can you understand that the main cause of ulnar nerve compression isn't a ligament, nor is it an anatomical alteration of the person, but something they do in their daily life that leads to this compression? So Deborah, I want to know something else. Do you believe that most of these cases need surgery?
No, they don't need it. I don't believe that, actually. Some patients come to me already having had an electroneuropathy. The more severe cases are generally surgical, right, Thomas? There's not much we can do in rehabilitation today that can improve it, although some patients don't want to undergo surgery. So we try to alleviate the symptoms, right? And then, how do we alleviate the symptoms? We can use ultrasound, laser, the use of orthoses, positioning, right? So you change how you are dealing with the factor that is causing it.
I have a question. That for me, I have the answer, but I don't know if it's the same answer as yours. Which is the following. If you could choose the laser, the ultrasound, the orthosis, or the change in her habit that triggered the symptom, and you could change one of them to solve her problem, which one would most increase her chance of solving the nerve compression problem?
The change in how she is causing the nerve compression. Although I think that often, the orthosis comes along with that, because it doesn't necessarily have to be the orthosis that we manufacture, Thomas. So often I see patients via video call and I can't make the orthosis, but I will make some kind of adaptation so they can sleep. So many times I place a towel on the ulnar nerve, for example. I place a towel so he doesn't close his arm too much. Sometimes I can teach him to apply kinesio tape just so the kinesio tape gives a sensation and he doesn't keep his elbow so bent. So I think changing the positioning is the best way.
And then I have one more question. People are difficult, right? We are people, we are also difficult. We understand that it's someone who has already had the symptom, which started slowly with tingling, pain. And then, they know they have this problem. Sometimes they even know that when they bend their elbow on the table, like I am now, it will cause the symptom. And they should stop doing this, so the problem doesn't continue to evolve. Yes, do you think most patients can avoid the triggering factor, or do most of them struggle with it?
From my experience, I think they struggle with it. I think the hardest part is patient education. It's very complicated.
And that's where I think the orthosis comes in, right?
Yes, exactly.
In fact, Deborah made an orthosis for me, which I use to sleep, because sometimes I use my phone a lot and I have a problem with my thumb and it bothers me. Surgery actually helps me because during surgery I make this cutting motion, which strengthens the opposing movement. But the phone, I use it like this and sometimes I can't avoid it, but when I'm using the orthosis you made, it helps me a lot. And then the person has no choice with the orthosis, right?
Exactly. So the orthosis serves this purpose, but if you're a disciplined person, because I agree that we are difficult, but there are patients who are very disciplined, right? So if you talk, if you explain the reason, and the patient understands, they will do exactly what you're asking. So with these patients, we don't need to use an orthosis. They will really follow the path, try to change the structure of the mouse, the keyboard, and so on. Sometimes the surgeon can't do it during surgery because it's not a material you can sterilize, but during the consultation or at night, the person will use it. So, if the patient can understand this, we have very good results with the guidance.
So, for those of you at home, if you have symptoms of nerve compression, shock, tingling, or pain, you need to pay close attention to when during the day this is worsening or occurring, because probably, not that it's 100%, but probably it's your fault. At some point, you are in a wrong position or doing some repetitive movement, and this is causing the problem. Rehabilitation, occupational therapy, and the use of orthotics are extremely important, but stopping the causal factor is also very important. You can only stop this factor if you know what you are doing.
What I have been doing with very good results, and I attend to well-informed people, I attend to many doctors, is I ask them to film their workbench, them working, because many times we have no idea what movement is really causing the nerve to be trapped, compressed. So, by filming, it doesn't need to be all day, but just a few minutes. Then they send it to me and I will analyze this behavior.
And what are the wrist and elbow postures that you see most often causing symptoms? The type of chair, the type of table, what do you see most often that bothers people?
So, I see the elbow. When the elbow is completely out, supported, or off the table or off the chair, that's a problem. Very much forward, whether it's too far forward or too far back, both, because we can have nerve compression, both here in the neck and in the elbow. And we can also have it in the wrist. So depending on your posture, you can have compression in these three places. That's why you can't just say it has to be straight or it has to be bent. We need to analyze the case, see where the compression is happening, and evaluate how you're using your upper limb in your daily life.
Folks, what she's saying is the following. That patient who keeps their arms too far forward because there's no support, or the mouse and keyboard are too far away, they keep their arm like this. As the arm stays like this, imagine you're pulling a power cable forward. What happens here in the neck? The nerve, the artery, and the vein twist, and we have thoracic outlet syndrome. You have the thoracic outlet syndrome course posted here on my channel. I'll leave the link below for you to watch later. And the person who keeps their elbow very bent back here, they bend the nerve here, they bend the nerve here, and by making these two kinks in the nerve, it causes the symptom. And what about at night? What do you ask? What do you notice? What do you suggest for the patient who has compression at night?
So, nighttime compression. Usually, if it's from the elbow, it's because the person sleeps on their side and rests their elbow, staying supported for a long time, or sleeps with their wrists flexed. Which is normal. We all sleep in flexion. It's rare to see someone, why do we all sleep like this? I used to sleep like that, not anymore, but I think I have to post saying something wrong. But I think it has a lot to do with the history of our formation. We are always more curled up, as a sense of protection. That's what I think.
And what do you do with this patient? Because we know we're sleeping wrong, right? We wake up with everything tingling. I had this problem of sleeping with my wrist and elbow bent, but during the day, everything would tingle. I even consulted with Deborah and she released my ulnar nerve, which was really tight at one point, and today, thank God, I don't have any tingling. Change of habit. How do you identify that the nighttime is the culprit? That he's sleeping and not fulfilling it during the day, but at night?
Based on the activities, the routine he tells me about. During the day, if he sends the video, I see that everything is okay. He's not someone who does weight training, and he also reports that during weight training he doesn't have this issue. I also have this issue with the nerve. The ulnar nerve works a lot with the hand, right? Exactly. And at the gym, if I push too hard, I also start to feel my paresthesia, my lack of sensitivity, right there at the gym. So, if the patient is already telling me, oh, I don't have difficulty, then it's only at night, right? Because then the patient sometimes says, no, I wake up a lot at night to release my arm, to get it back to normal. Then they even say it's blood. They never think it's a nerve, they think it's circulation. So then I already identify that it's during the night and not during the day. If the patient is close to me, or if they decide to make the orthosis, I make the thermoplastic orthosis, or we use something else like a towel or a sponge to prevent them from bending the elbow too much. But it's not just the bending, right, Tom? Sometimes it compresses when you lean on it. So, if that's the situation, I also make something like a little cushion leaving the elbow open. These are simpler things, so when it's nighttime, in the case of the nerve in the elbow, we have these two options. Because if it's due to support, the cushion here, leaving it in semi-flexion, won't work. So I have to make the little cushion here on the elbow.
Deborah, tell me something. When it's a nerve that isn't motor, it's only sensory, and the person has pain. Because today, for example, I performed surgery on a patient who had compression of the fibular nerve. He started with loss of strength, regained strength, and was left with pain. What can he do to improve this compression symptom that already presents directly as pain? What do you recommend? What do you do? A tip even for people who are going to rehabilitate patients with nerve compression. What do you usually do in rehabilitation that helps this patient improve? Neuropathic pain?
After surgery.
Before surgery, without surgery. I don't want to operate on anyone today. Operated earlier.
So, neuropathic pain is quite complicated, right, Thomas? Especially because it goes in a circle, and if we can't interrupt this signal going to the brain, it becomes very difficult. And the longer the person has this pain, the harder it is. Today we have the use of laser.
No, I understand, but let's not talk about that patient who has been in pain for a long time. People who have been in pain for a year, 2 years, where rehabilitation doesn't help and sometimes even surgery doesn't solve it. You have to do chronic pain treatment. Mild cases, where you say, no, let's give a good shot at rehabilitation, because it might be that they, or especially in that case where the person, I don't know, slept on their arm or kept their leg crossed for too long and then developed that pain. In other words, it was a trauma cause, so they have a chance to improve. What do you do there?
I would perform a myofascial release. There, try to release the nerve where it was compressed. I wouldn't apply ice because it's already compressed. I would try to apply heat, but more superficial heat, considering the patient is at home, not visiting the office. So some heat, a little bit of massage, I think would be good. But not a very superficial massage, a slightly deeper massage. And I think you could apply a little bit of kinesio tape. Applying kinesio tape is not difficult, so you can even find many videos on the internet teaching how to apply it, because there's a type of application where we try to create some space in there. We create a space, that's what the literature says, and for some patients, this helps a lot.
Do you recommend movement or staying still for this patient with nerve compression? Do you think that by moving, this patient will release the nerve? Or do you think they need to stay still to wait for the nerve to heal there? If you had to choose one of the two, or what is the perfect balance for the patient to have the best outcome?
I think the balance is just stretching, but what I've seen is that some people do stretching with load for the patient, right? So, you can't do that. So, with stretching, you can mobilize the nerve, mobilize the tendon, without so much force. Let's say, without losing so much mass, and it will be able to move in that tighter channel, but it will be able to mobilize both the nerve and the tendon, but not with load, right? Because, let me just explain a little, so many times the person, let's say one stretch is this, another stretch is if I take the wall and push the wall. That's not it, right?
So it's just a stretch. I can even use the wall, but I'll just, and for example, it has a maximum. You stretch until you feel pain there, or then you go back a little or hold it and then push a little more.
I think that stretching is always important, especially in these cases, because he doesn't have a reduced range of motion, so it's a stretch. You might feel some discomfort, then stop and hold it there. I always ask to hold for 5 to 10 seconds and do about 10 repetitions, and you can do it once or twice a day only.
Folks, so today we gave a little taste on the topic of pinched nerves. This class is generic, so it applies to nerves in the leg, nerves in the arm, nerves in the hand. Any type of nerve, anywhere in the body, can be pinched, either because of an accident or because it is under pressure throughout the day. The treatment is not much different from one to another. If you have loss of sensitivity, loss of strength, or pain that doesn't improve, sometimes surgery is needed. If it's a milder case, or you are improving, or where you can stop doing certain things, rehabilitation is extremely important. Remember that even if you have surgery, postoperative rehabilitation is very important, especially when you have surgery for a pinched nerve. So you understand that a patient who has a greater genetic predisposition to have a pinched nerve after you decompress the nerve. If he stays inactive for 30 days waiting for the nerve to regenerate, after 30 days he'll try to move and won't be able to because the nerve will be stuck to the scar. So it's essential to really intensify the release of the nerve and movement in the postoperative period. Anything else, Deborah?
Thank you very much, everyone. Now follow the upcoming videos.
Follow our channel.